Hello and welcome to this podcast by the Podmedics. For other similar podcasts, supporting materials and book reviews, please visit www.podmedics.co.uk. So this is a chemical pathology podcast on calcium handling. In this podcast I'm going to talk about calcium homeostasis and then hypocalcemia and hypercalcemia. Most calcium in the body is stored intracellularly, mostly in the bone, and there is only a small amount in the extracellular fluid. The serum calcium is usually regulated between 2.2 and 2.6 millimoles per litre, and it's important to know that a calcium over 3.5 contributes a medical emergency. Of the calcium in the blood, 50% is unbound or ionized, and this is the physiologically active calcium, while the other 50% is bound to albumin. This calcium-albumin binding is pH dependent and decreases with acidosis while it increases with alkalosis. While it is possible to measure only the unbound calcium, the lab routinely measures the total calcium concentration and then corrects for the albumin. This is necessary because if albumin concentration falls, total serum calcium is low because the bound fraction is decreased. Most commonly, corrected calcium is acquired using the formula serum calcium plus 0.02 times 47 minus the albumin. This basically means that the measured calcium is adjusted by 0.1 millimoles per litre for every 5 grams per litre that the albumin is less than 47. Levels of calcium in the blood are regulated by parathyroid hormone produced by the parathyroid glands. This has actions on 3 important target organs. These organs are the bones, the kidneys, and indirectly the gut. Calcium-sensing receptors in the parathyroid glands detect levels of unbound calcium in the blood and, if low, release parathyroid hormone. As we've already said, this has an action on 3 important organs. First of all, in the bone, it causes resorption of bone with a net efflux of calcium. In the kidney, it causes conservation of calcium, as well as alpha-hydroxylation of 2,5-dihydroxycholecalciferol to 1,2,5-dihydroxycholecalciferol, or calcitriol. This hormone calcitriol, or vitamin D, or activated vitamin D, then enhances absorption of calcium from the smooth intestine. So there is a net increased concentration of calcium in the blood. Of pathological note, mutations in the calcium-sensing receptors of the parathyroid hormone cause the condition Familial benign hypercalcemia. This is a condition where there are usually no symptoms of hypercalcemia, but as the PTH is detectable, patients are often labelled as having primary hyperparathyroidism and often have their glands removed. For this reason, asymptomatic hypercalcemia in a relatively young patient should be regarded as possibly due to this condition. Now moving on to disorders of calcium homeostasis. There are, of course, 2 disorders, hypocalcemia and hypercalcemia. In each of these, it's important to have the most common causes readily available for recall, so these should just be memorized. It's also important, once the calcium concentration has been documented, measure serum PTH, as this often gives quite a clue into the etiology. So, hypocalcemia is defined as a calcium less than 2.2 millimoles per litre. The common cause to remember is parathyroid removal, say after neck surgery. Other important causes are vitamin D deficiency due to either malabsorption, malnutrition, or lack of exposure to sunlight, renal disease, where the diseased kidneys fail to synthesize calcitriol, and pseudo-hypoparathyroidism, where there is a failure of target tissue receptors to respond to the hormone. A good diagnostic approach in hypocalcemia is to first confirm via calculation of the corrected calcium that in fact a hypocalcemia is present. Then to do U's and E's to consider if renal disease is the cause. Then to measure a PTH. If the PTH is low in the presence of a low calcium, it suggests that the parathyroids are not working properly, and this is most commonly due to surgery. However, it's important to remember that magnesium deficiency can also cause this. If the parathyroid level is high, we wonder why the calcium is not normalized, and this will usually be because of either vitamin D deficiency or pseudo-hypoparathyroidism. If you remember, we've already excluded renal disease. Clinically, hypocalcemia may of course be asymptomatic. However, its symptoms may be divided into neurological, cardiac, and ophthalmic sets. Neurological symptoms include increased neuromuscular excitability leading to fits, and Trousseau's sign, where there is carpal spasm if you inflate a BP cuff over the systolic pressure and leave it for 2 minutes. Cardiac symptoms include a prolonged QT interval and hence arrhythmia, and important eye symptoms include cataracts. Treatment-wise, mild hypocalcemia can be treated with calcium supplements, and more severe hypocalcemia is often treated with vitamin D, the activated form, so 1,2,5-dihydroxycholecalciferol, or synthetic vitamin D, 1-alpha-hydroxycholecalciferol. So I'm now going to talk a little bit about hypercalcemia. The important causes of hypercalcemia to remember are primary hyperparathyroidism, usually due to a small single parathyroid adenoma secreting PTH independently of feedback control by plasma calcium. The other is malignancy, which can cause a hypercalcemia either due to bone destruction from bony metastases or via production of PTH-related protein. Other causes are granulomatous disease, so TB or sarcoid. This occurs mainly because these granulomas are able to independently synthesize activated vitamin D3. Vitamin D intoxication, say in the treatment of hypoparathyroidism or renal disease. Diuretic therapy, where the hypercalcemia is usually mild. Renal disease due to long-standing secondary hyperparathyroidism leading to independent PTH secretion by the parathyroids. This is termed tertiary hyperparathyroidism. Lastly, milk alkali syndrome, where there is an increased calcium intake together with bicarbonate, usually in the form of an antacid. Diagnostically, the approach is largely as for hypocalcemia. So first of all, there should be confirmation of serum calcium and albumin and calculation of the corrected calcium. Then the question should be asked, is the PTH appropriate to the serum calcium? So if the PTH is undetectable, this implies that the pathology is outside the thyroid gland, with calcium becoming high enough to suppress it. And of course this is usually due to malignancy, but may be due to the other causes we spoke about, so granulomatous disease, vitamin D intoxication, or milk alkali syndrome. If the PTH is present or high, this of course implies a parathyroid source, so primary hyperparathyroidism, usually because of an adenoma. Clinically, patients may present asymptomatically or with the characteristic bones, stones, groans, and psychic moans. Bony changes occur due to high circulating levels of PTH, causing a characteristic pattern of bone resorption, which is known as osteitis fibrosa cystica. However, this is rarely seen nowadays as hypercalcemia is detected before this can occur. Stones refers to the presence of kidney stones in association with a high calcium. However, thirst and polyuria due to a nephrogenic diabetes insipidus induced by the high calcium levels often presents first. Groans refers to abdominal symptoms such as pain, nausea, vomiting, and constipation, and psychic moans refers to a general weakness and fatigue, often with altered mental state. As we said earlier, a calcium greater than 3.5 millimoles per litre is an emergency and requires immediate treatment with fluids to promote a diuresis of calcium, and bisphosphonates to inhibit further bone resorption. Obviously, if the cause is primary hyperparathyroidism, the parathyroid adenoma needs to be removed surgically. So that completes the podcast on calcium homeostasis and pathology. Thanks for listening to this podcast. Please visit our site at www.podmedics.co.uk for more podcasts and additional supporting materials.